strabismus. So for understanding strabismus, we must know about the anatomy and physiology of the ocular motility system. The extraocular muscles, there are 6 extraocular muscles, 4 rectus and 2 obliques. The rectus muscles are the superior rectus, inferior rectus, medial and lateral rectus, and the 2 oblique muscles are superior and inferior oblique. This is the arrangement of the oblique muscles around the globe. The medial rectus muscle arises from the annulus of Zinn, all the 4 recti arising from the annulus of Zinn, and the length of these muscles is 40 millimeters. Their anatomical insertion is about, the medial rectus inserts 5.5 millimeters from the limbus, lateral is 7 millimeters from the limbus, then inferior is 6.5 and superior rectus is 8 millimeters from the limbus. The length of superior oblique is about 32 millimeters. It arises from the orbit apex above the annulus of Zinn, and from the temporal pole of the superior rectus, its insertion is within 6.5 millimeters of the optic nerve. The inferior oblique is about 37 millimeters long, arising from the lacrimal fossa and inserted in the macular area. The origin and insertion, all the 4 recti, they originate from the common tendinous ring, which is the annulus of Zinn, attached at the apex of the orbit encircling the optic foramen. The medial rectus arises from the medial part of the ring, superior rectus arising from the superior part and also from the adjoining dura covering the optic nerve, inferior rectus from the inferior part, and the lateral rectus arises by 2 heads, forming a V in the lateral side of the annulus of Zinn. This is the annulus of Zinn around the optic nerve at the orbital apex, and this is the superior rectus, that's inferior rectus, medial and lateral rectus. That is the superior oblique muscle. All the 4 recti, after originating from the annulus of Zinn, then they run forward around the eyeball and are inserted into the sclera at different distance from the limbus. Medial rectus 5.5, then inferior 6.5, lateral 6.9, and superior rectus is inserted in the sclera about 7.7 millimeters from the limbus. This is the insertion of the recti. Again, diagrammatic representation showing the insertion of the various rectus muscles into the sclera about this much millimeters from the limbus. 5.5, then inferior 6.5, easy to remember it this way. 5.5 medial rectus, then this is the inferior, this is lateral, and the superior rectus about 7.7 millimeters. The limbus. The superior oblique muscle arises from the bone above and medial to the optic foramen. It then runs forward and turns around the pulley, the trochlea, present in the interior part of the supromedial angle of the orbit, and is then inserted in the upper and outer part of the sclera behind the equator. The inferior oblique muscle arises from a rounded tendon from the orbital plate of maxilla, just lateral to the orifice of the nasolacrimal duct. It then passes laterally and backward to be inserted into the lower and outer part of the sclera behind the equator. The nerve supply. The extraocular muscles, they are supplied by the 3rd, 4th and the 6th cranial nerve. You have a formula here, SO4 LR6. That is the superior, SO is for the superior oblique muscle supplied by the 4th nerve, the trochlea, SO4. LR6, the lateral rectus supplied by the 6th nerve, that is the abducent, and all the rest of the extraocular muscles, superior, medial, inferior rectus and inferior oblique muscles, they are supplied by the 3rd cranial nerve, that is the oculomotor nerve. The extraocular muscles, they rotate the eyeball around the vertical and horizontal and the enteroposterior axis. The medial and the lateral rectus, they are mostly parallel to the optical axis. So they have only one action, that is to rotate the eyeball either medially or laterally. The superior and the inferior rectus muscles, they make an angle of 23 degrees, and the reflected tendons of superior and inferior obliques, they make an angle of 50. The recti, superior and inferior, making an angle of 23 degrees with the optical axis, and superior and inferior obliques, they are making an angle of 51 degrees with the optical axis in the primary position. So in addition to the main function, they will also have a subsidiary action. Ocular motility. So the ductions, what are ductions, what are versions, and what are vergences movement. Duction, supraduction, infraduction, like that. Ductions are when there is movement of only one eye. Ductions are monoocular movement in the various positions of gaze. Versions are dextroversion, levoversion, like that. Versions are binocular movement in one direction, and vergences are binocular eye movements in opposite direction. We'll deal in details with that. So this is the primary position, and ductions have been shown here. Duction, which is a monoocular movement. The primary position of the eye, when one eye moves medially, this is adduction. When one eye is moved laterally, this is abduction. When the eye moves up, is supraduction, this is infraduction. And when the upper 12 o'clock position of the cornea moves inward, that is intorsion, and that is extorsion. So the unilateral movements are called ductions. So adduction is the inward movement or the medial rotation along the vertical axis. Abduction is the lateral rotation along the vertical axis. When this eye moves inward, it is adduction. When it moves outwards, it is abduction. When the eye is moving upwards, that is elevation, that is supraduction. The downward movement or depression along the horizontal axis is infraduction. And encycloduction or intorsion is a rotatory movement along the enteroposterior axis in which the superior pole of the cornea, that is the 12 o'clock position, moves inwards. And when the upper superior pole of the cornea moves laterally, that is known as excycloduction or extorsion. So the actions of extraocular muscles in the primary position, I told you the medial rectus and lateral rectus, they have only one primary function, that is adduction by medial rectus and abduction by lateral rectus. And all the other muscles, they have a primary function as well as a secondary and tertiary function. So primarily the inferior rectus will cause depression. Along with this, it will also cause extorsion and adduction. Superior rectus will cause elevation, intorsion, adduction. Inferior oblique will, the primary function of inferior oblique is extorsion. Along with this, it causes elevation and abduction. The superior oblique causes intorsion, depression and abduction, and the levator palpebris superioris, this causes elevation of the upper eyelid. Now the binocular movements, which are known as the versions. Versions are the conjugate movements, the symmetrical movement of both the eyes in the same direction, like you call dextroversion, which will mean the movement of both the eyes towards the right. It will be because of the simultaneous contraction. Now both the eyes moving towards right means the lateral rectus of the right eye and medial rectus of the left eye will help in dextroversion. Now levoversion. Levoversion will be the conjugate movement of both the eyes towards the left. So this will cause contraction of left lateral rectus and right medial rectus. Then supraversion will be because of contraction of both the superior rectus and inferior oblique. Then infraduction will be because of the simultaneous contraction of both the inferior recti and superior obliques. Dextro elevation. Dextro elevation, that is movement right and up. It will be because of contraction of right superior rectus and left inferior oblique. Similarly, levo elevation, dextro depression, dextro elevation, then dextro depression, right and down. So this will be because of right inferior rectus and left superior oblique. Levo elevation, that is left and up. So this will be because of left superior rectus and right inferior oblique. Similarly, levo depression will be because of left inferior rectus and right superior oblique. Dextrocycloversion will be the rotatory movement along the anteroposterior axis in which the superior pole of the cornea of both the eyes will be tilted towards the right, and levocycloversion when the superior pole of cornea of both the eyes will be tilted towards the left. Now the binocular movement, which is vergensis. This is a disconjugate movement in which there is movement of both the eyes in the opposite direction, like convergence, in which both the eyes are moving in the center, and this will be because of the contraction of medial rectus of both the eyes. Divergence is outward movement of both the eyes, and this will be produced by the contraction of the lateral rectus of both the eyes. Now, what are synergists? In the movement of the eye, which muscles will be known as synergist, which will be antagonist, and which will be the yoke muscles. Synergists are the muscles having similar primary action in the eye. That is, superior rectus and inferior oblique of the same eye will be the synergist elevators. Antagonist will be the muscles having opposite action in the same eye. That is, medial rectus and lateral rectus. They are antagonists. Superior, inferior rectus and superior and inferior obliques are the antagonists in the same eye. And yoke muscles. Yoke muscles are the pair of muscles which are contracting simultaneously in bringing about the version movement. That is, like it is a dextroversion. So, the right lateral rectus and left medial rectus, these will be known as the yoke muscles. Contralateral antagonists are the pair of muscles, one from each eye having opposite actions. That is right lateral rectus and left lateral rectus, right medial rectus and left medial rectus. So there are certain laws governing the ocular movements. First is the Hering's law of equal innervation. What is Hering's law of equal innervation? It says that an equal and simultaneous innervation flows from the brain to the pair of muscle which contract simultaneously, like the yoke muscles, in bringing about the various binocular movement. Like in dextroversion, right lateral rectus, left medial rectus, they are contracting. So equal and simultaneous innervation will flow to both the muscles. During convergence, both the medial rectus will have equal innervation. Okay? So this is the Hering's law of equal innervation. What is second law is Sherrington's law of reciprocal innervation. It means that during ocular motility, increased flow of innervation to the contracting muscle will be accompanied by decreased flow of innervation to the relaxing antagonist muscles, which means if you have to move in dextroversion, increased innervation flow to the right lateral and left medial will be accompanied by decreased flow to right medial and left lateral. क्योंकि अगर यहाँ पे innervation is increasing, अगर उसके antagonist contract नहीं करेंगे तो I तो primary position में ही रह जाएगी ना. So Sherrington's law of reciprocal innervation means when any muscle to bring about the movement, अगर जो similar muscles when they are bringing about the movement कब होगा? जब उनकी antagonist relax करेंगे. So during ocular movement, increased flow of innervation to the contracting muscle will be accompanied by decreased flow of innervation to its antagonist for any ocular movement to take place. This is known as Sherrington's law of reciprocal innervation. Now, the various diagnostic positions of gaze. Diagnostic position. What is the primary position of gaze? There are 9 diagnostic positions of gaze, out of which 1 is primary, 4 secondary, and 4 tertiary. The primary position of gaze is this position. It is assumed when both the eyes are fixed straight. It is the position assumed by the eyes when fixating a distinct object when the head posture is erect. This is the primary position of gaze. Now, what are the 4 secondary positions? The 4 secondary positions are up, down, lateral, and medial. These are the 4 secondary positions. The secondary positions of gaze are the positions assumed by the eye when they are looking straight up, straight down, right, and left. These are the secondary positions of gaze. And what are the tertiary positions of gaze? Is when you are looking right lateral, right upper, and left down. Those are the tertiary positions of gaze. That is in dextro elevation, dextro depression, levo elevation, and levo depression. And these together form the 9. The primary position of gaze, 4 secondary and 4 tertiary. They form the 9 positions of gaze. Now, what is the cardinal position of gaze? These are the positions which allow examination of each of the 12 extraocular muscles in their main field of action. And the 6 cardinal positions are dextro elevation, dextroversion, dextro depression, levo elevation, levoversion, and levo depression. These are the 6 cardinal positions of the gaze. Now, very important, binocular single vision. This is important from the examination point of view also. Now, what do you mean by binocular single vision? When a normal individual fixes his visual attention on any object of regard, the image is formed on the fovea of both the eyes separately, but the individual perceives the vision as one. We have 2 eyes, but we see every object as one. So, in other words, binocular single vision is the coordinated use of both the eyes so as to produce a single mental impression. So, the development of binocular single vision. It is a conditioned reflex which is not present since birth, and it is acquired during the first 6 months of age and completed by the first 6 years. The important milestones in the development of binocular single vision are: at birth, there is no central fixation. The eyes are moving randomly. By the first month of life, the fixation starts developing and it is complete by 6 months. 6 months पे macular stereopsis and accommodation reflex is fully developed, and by 6 years of age, the binocular single vision gets completely developed. So now, what are the prerequisites for the development of a binocular single vision? Straight eyes. ठीक है ना? If the eyes are diverging or they are converging, if there is any manifest squint, then again the binocular single vision will not develop. So the first requisite is to have straight eyes starting from the neonatal period with precise coordination for all the directions of gaze. That is the motor mechanism. Reasonably clear vision in both the eyes so that similar images are presented to each retina. That is the sensory mechanism. And then the ability of the visual cortex to promote the binocular single vision. That is the mental mechanism. Any pathological state causing disturbance in any of these mechanisms, motor mechanism, sensory mechanism, and the mental mechanism, will cause a problem in the development of the binocular single vision. Now, the grades of the binocular single vision. Simultaneous macular perception, this is fusion, and this is stereopsis. These are the slides for the 3 grades of the binocular vision, which we'll study in detail. So, Wirth has described 3 grades of binocular single vision, which can be tested with the help of synoptophore. The grade 1 of binocular single vision is simultaneous perception or simultaneous macular perception. It is the power of the eyes to see 2 dissimilar objects simultaneously, and so it is tested by projecting 2 dissimilar objects which are joined in front of both the eyes. That is a bird in a cage. For the simultaneous macular perception, you will project the picture of bird onto the right eye and cage on the left eye, and a person with a normal binocular vision or a person with a normal simultaneous macular perception will see bird in the cage. The second grade of binocular vision is fusion. This is the power to superimpose 2 incomplete but similar images to form one complete image. The ability of the subject to see one complete image when his eyes are made to converge or diverge a few degrees give positive and negative fusion rays respectively. And the slide for fusion is a rabbit with a tail and a rabbit with a bouquet, and a person with normal fusion will be able to see rabbit with a tail and a bouquet. Then the third grade of binocular vision is stereopsis. This consists of ability to perceive depth. Depth perception is known as stereopsis. So this will be the slides of bucket, and you will be able to see bucket with the depth perception, a person having normal stereopsis. Now, what are the anomalies of the binocular vision? Anomalies of binocular vision are suppression, amblyopia, abnormal retinal correspondence, confusion, and diplopia. Out of this, amblyopia and diplopia as a separate entity, you can have short notes on them. Suppression, amblyopia, abnormal retinal correspondence, confusion, and diplopia. These are the anomalies of the binocular vision. This is slides of confusion and diplopia. First is suppression. Suppression is a temporary, active cortical inhibition of an image of an object formed on the retina of the squinting eye. This phenomena occurs only during binocular vision when both the eyes are open, and when the fixating eye is covered, the squinting eye fixes, the suppression disappears. And to test the suppression, Wirth 4-dot test, 4 diopter prism based out test, red glass test, synoptophore test. Amblyopia. Amblyopia is very important because in your OPDs you may see many patients, small, young children coming with good vision in one eye and vision not improving at all in the other eye. Patients having amblyopia is a very frequent finding. Amblyopia refers to a partial reversible loss of vision in one or both of the eyes for which no cause can be found by the physical examination of the eye. There is no organic disease, but when you test the eye, vision of usually one of the eyes is very less, about 660 or 636 only. Amblyopia is produced by certain amblyogenic factors operating during the critical period of visual development, that is from birth to 6 to 7 years of age. During this period, the visual pathway continues to develop and the brain learns to interpret the signals coming from the eye. So, amblyogenic factors can be in the form of visual factors, deprivation as it occurs in cases of anisometropia. It can be due to light deprivation as in congenital cataract, or sometimes because of abnormal binocular interaction as occurs in cases of strabismus. Now, the various types of amblyopia. First is the strabismic amblyopia. This results from the prolonged uniocular suppression in children with a unilateral constant squint which fixates with the normal eye. Squint is a very important cause of amblyopia. When one eye is seeing, the other eye is squinting and you're not correcting the squint of that eye, so the squinting eye might go into amblyopia. Stimulus deprivation amblyopia occurs when one eye is totally excluded precluded from seeing in the early ages of life, which could be because of congenital or traumatic cataract, complete ptosis, and a dense central corneal opacity. एक eye का vision ही नहीं बनता. The patient is seeing with one eye and not seeing with the other eye. So the other non-seeing eye goes into amblyopia. An isometropic amblyopia occurs if one eye is having a 6/6 vision and the other eye is having a high refractive error. Again, an anisometropic amblyopia develops. Meridional amblyopia occurs in patients having a high degree of squint. So the clinical characteristic of an amblyopic eye: the visual acuity is reduced, recognition acuity is more affected than the resolution acuity. Then effect of neutral density filters. Visual acuity, when it is tested through the neutral density filter, improves by 1 or 2 lines in amblyopia and decreases in patients with organic lesions. Crowding phenomena is present in amblyopics. So the vision will be less when you are testing with multiple letter charts like in Snellen's chart than when you are tested with single charts. So this is known as a crowding phenomena. अगर single chart से देखेंगे ज़्यादा अच्छे पढ़ पाएगा as compared to when there are multiple letters like in Snellen's chart. This is known as crowding phenomena and is seen in amblyopic patients. Fixation pattern may be central or eccentric. Degree of amblyopia and eccentric fixation is proportionate to the distance of that eccentric point from the fovea. Color vision is usually treatment of amblyopia. The treatment of amblyopia should be started as early as possible. First is occlusion therapy, in which you will occlude the sound eye so as to help the amblyopic eye to start working. Occlusion of the sound eye will force the use of the amblyopic eye. It is the mainstay of treatment in amblyopia. However, before the occlusion therapy is started, you should also see that koi opacity in the media to nahi hai, then that has to be corrected first. And if there is any refractive error, then that is also to be corrected first. Methods of occlusion can be accompanied by any adhesive tape on the skin, gauge pad, taping hair, use of Doyner, rubber occluders which will stick onto the spectacle lens, opaque contact lenses, adhesive tapes on the glass, giving a ground glass occluder. Now, types of occlusions are a full-time occlusion. This will involve occlusion of the sound eye in all the waking hours or all but one waking hour a day. A simplified occlusion is up to 2 years, that is 2:1. That is 2 days you occlude the sound eye and 1 day in the amblyopic eye. 3:1 in 3 years of age hai. If the child is of 4 years, then 4:1. Matlab 4 days you will occlude the sound eye and 1 day you will occlude the amblyopic eye. At the age of 5 years, 5:1. After the age of 6:1 is the part-time occlusion. Conventional, the given schedule will be the same. However, as per the amblyopic treatment study, part-time occlusion matlab only 4 to 6 hours per day occlusion of the normal eye. Penalization. That is, second is after the occlusion. Second is method of treating the amblyopia is penalization. That is blurring of vision of the normal eye, either by using atropine, known as atropine penalization, or by using over plus lenses. Occlude kiya hai aapne basically. Over plus lenses in the spectacles is known as an optical penalization. Pleoptic exercises to re-establish the foveal fixation, and pharmacological manipulation by giving levodopa or carbidopa are also being studied as an adjunct to the occlusive therapy. Now, what is an abnormal retinal correspondence? In a state of normal binocular single vision, there will always exist a precise physiological relationship between the two corresponding points of the retina. However, the fovea of the two eyes, they have corresponding points रहता है with the normal visual axis. This adjustment is the normal retinal correspondence. When squint develop, patient will have confusion या diplopia. So what is an abnormal retinal correspondence? So to avoid this, diplopia or confusion, the squinting eye develops some abnormal point which now starts corresponding to the fovea of the normal eye. So to avoid this occurs an active cortical adjustment in the directional value of the two retina. In this state, the fovea of normal eye and in any other extrafoveal point of the retina of the squinting eye, now they start behaving as corresponding points. So नॉर्मल आई और स्क्विंटिंग आई का एक्स्ट्रा फोवियल पॉइंट, वो दोनों करस्पॉन्डिंग पॉइंट जैसे बिहेव करने लग जाते हैं. सो नाउ द पर्सन विल नॉट हैव डिप्लोपिया कंफ्यूजन, पर्सन हैविंग स्क्विंट but will have a normal binocular vision. So this is known as abnormal retinal correspondence. Diplopia. What is diplopia? It is the simultaneous perception of two images of the single object. Diplopia मतलब आप एक ऑब्जेक्ट को देख रहे हैं लेकिन वो दो दिख रहे हैं, मतलब there is a disturbance in the binocular vision. Now diplopia can be binocular diplopia, means when with both the eyes open. Uniocular diplopia मतलब you are seeing two with one eye open. Binocular diplopia occurs due to formation of images on the dissimilar points of two retina. In uniocular diplopia, an object appears double from the affected eye even when the normal eye is closed. Binocular diplopia occurs because of formation of image on two dissimilar points of the two retinas. Now, what are the causes of binocular diplopia? Paresis or paralysis of the extraocular muscle, displacement of one eyeball as occurs in space occupying lesions of the orbit या fracture हो रहा है, mechanical restriction in the ocular movement. So in the direction of the gaze, अगर बहुत बड़ा pterygium है या symblepharon है or there is a thyroid of ophthalmopathy, if there is a mechanical restriction ocular movements, again there will be diplopia in the direction of the restrictive gaze. Deviation of the ray of light in one eye because of decentered spectacle or anisometropia. These are the causes of the most important is paralysis or paresis of the extraocular muscle, where there will be diplopia in the direction of the gaze of the paralyzed muscle. Binocular diplopia can be crossed or uncrossed. Uncrossed diplopia, the false image is on the same side as the deviation. This will occur in convergent squint. Cross diplopia, the false image is seen on the opposite side. This will occur in cases of divergent squint because of medial rectus palsy. Now, we'll see the causes of uniocular diplopia. In uniocular diplopia, an object appears double from the affected eye even when the normal eye is closed. What are the causes of uniocular diplopia? Subluxated clear lens. अगर lens subluxate हो गया, so there is lens in half of the eye and half of the area is aphakic, so the patient will see a uniocular diplopia. A subluxated intraocular lens. Then the pupillary area is going to be partially aphakic and partially pseudophakic, double pupil. Any congenital anomaly hai, or you have done a large peripheral iridectomy or iridodialysis because of any blood trauma. Incipient cataract, usually polyopia because of multiple images because water in between the lens fibers. So these are the causes of uniocular diplopia. Treatment is you have to treat the cause, and temporary relief from the annoying diplopia can be obtained by occluding the effect.